So welcome everyone to our first hybrid community event hosted by the Community Researcher Engagement Program here at Monash CCS. We are so excited to have you all joining us from the comfort of your own home or in person. I would like to begin to acknowledge the traditional owners of the land on which we meet today, and I would also like to pay my respect to the elders past and present. My name is Dr. Catriona. I'm a research group leader at the Australian Centre for Blood Diseases here at Monash University. The CaRE program was developed to facilitate effective engagement between researchers at the CCS and the members of the community who have lived experience of the health condition or diseases that we are studying. By understanding and learning from the unique and valued patient perspective, we ensure that the research we undertake is appropriate, accessible, and relevant to the needs of the people impacted by those diseases. An important part of the CaRE program is to run series of public events. These events are intended to provide you all, the members of the community, with the most up-to-date information on the cutting-edge research we are doing and performing here at the CCS. Before I hand over to Professor Steve Jain to start this event, I'd like to say thank you to our sponsors, Advocacy and CaRE. I just want to also get over a couple of housekeeping items. So please feel free to add comments or feedbacks to the chat box at the bottom of your screen throughout the event. If you would like to answer questions from our expert panel, please feel free to drop the question in the Q&A. You will find it as well at the bottom of your screen. It is most important to note that our experts will not be able to answer any questions related to an individual person's circumstances, clinical diagnosis, or current treatments. We therefore ask you to please focus your questions around the topics being discussed by the speakers this evening. Without further ado, I would like to hand over to our moderator for this evening, Professor Steve Jain. Professor Steve Jain completed his medical degree at Monash University. He entered the physician training program at the Alfred, completed clinical laboratory in hematology, and his PhD under Professor Hatton Sam, director of the Australian Centre for Blood, previous director of the Australian Centre for Blood Diseases. He then spent 5 years in the United States before he returned to Australia in 1995 as a welcome senior research fellow at the University of Melbourne at the Bone Marrow Research Laboratory in the Royal Melbourne Hospital. Professor Jain was appointed as the head of clinical school, professor of medicine, Monash University, and director of the research for Alfred Hospital in 2011. He was made foundation dean of the new sub-faculty of translational medicine and public health at the Alfred Research Alliance precinct in 2019. Professor Jain has a range of research interests, investigating both development in acute disorders, blood and skin models. He currently holds a number of NHMSC grants and other competitive grants. He has published over 90 papers, including in Science and Nature Medicine. Please join me to welcome Professor Steve Jain.
So firstly, I'd like to welcome everybody who's come in person and brave government warnings and the elements to get here. I think Catherine and Karen, who've been the instigators of our community engagement group, have done an incredible job. They've been able to put this together after many attempts, hampered largely by COVID on a number of occasions, but finally get it to the line. But the one thing Karen couldn't control was the weather, unfortunately. So I think that's going to reduce the number of people who come in person, but hopefully many will come online. Community engagement is an emerging facet of what we all need to do in both our clinical lives and our research lives. our governments, our funding agencies, our hospitals are all demanding greater community engagement, and I think this is not before time. I think we've always tended to look at consumers as the end part of the journey rather than involving them in the beginning, and I'm pleased to see that this is gradually transitioning and that more and more consumers are involved in the genesis of studies at research and clinical trial level. I'm delighted to see members of our consumer groups here, delighted to see them on our speaking list tonight, and I think this is a really positive step forward for us all in both our research and clinical trial activities for the future. We've got a star-studded list tonight, I have to say. Professor Andrew Perkins, who I've known for more years than I actually care to remember, as an international clinician-scientist in the area of myeloproliferative neoplasms. We have Mr. Ken Young, who I had the pleasure of meeting briefly before tonight. Event was getting underway, who has a broad experience, not only in the clinical sphere of myeloproliferative neoplasms, he was telling me, but also in consumer advocacy and involvement. Always delighted to see young female researchers, and we have Charlene Lam, who's a PhD student, who's going to talk about her work in MPN. And finally, we have Catriona, Rafael, who's the Manager of Policy and Advocacy for the Leukaemia Foundation. So really good spectrum of both research, consumer advocacy and consumers themselves, and I think it will be a program that we'll have much to enjoy from. So I'll start off by introducing Andrew. As I said, I've known Andrew for a long time. We were in the USA together. He's a professor of haematology and head of genomic medicine at the Alfred Hospital in Melbourne. He holds joint professorial position at Monash University in the Australian Centre for Blood Diseases and is a group leader in blood cancer genomics. Andrew undertook his clinical training north of here in the Royal Prince Alfred in Sydney. He had a PhD in genetics in one of Australia's foremost institutes, the Walter and Eliza Hall, and then a very celebrated postdoctoral period at Harvard University, where I first got to know him, usually looking in awe at the research work he was generating, to be honest. He's a world expert in myeloproliferative neoplasms, and I think the great strength of Andrew is he spans the continuum all the way from the basic science in the laboratory through to patients and clinical trials and everything in between. And certainly that is one of the great attractions and one of the reasons why I fought so hard to recruit him down from Queensland successfully. He's a member of the ALG subcommittee on myeloproliferative neoplasms, has 8 active clinical trials in myelofibrosis, head of molecular pathology at the Alfred, and runs inter-hospital MDTs to help clinicians find the best management plans for patients with myeloproliferative neoplasms. Can't think of anyone better to lead off a session than Andrew, a truly international expert, and I call him to the podium and thank you very much for his time.
Well, thanks for that lovely invitation, and thanks for all of you coming tonight. This is the first time I've been involved with such an event where we have speakers and people that I've emailed a lot, like Natalie, in the MPN world out there. And as Steve said, you know, it is very important and increasingly important for us to interface with you in a two-way fashion. So we're interested in what you tell us from a point of view of what your symptoms are, what could be done better, what your needs are, and we're interested very much in trying to keep you up to pace, because I know you're interested in new horizons with respect to new medicines. This is a busy slide. I want to start off by thanking Karen, who has put aside her usual research duties to get this event up, and it's been a long journey. So thank you, and to all of your committee, I really appreciate it. There's a little slide there on what the CaRE committee is all about. I want to thank the sponsors also, so AbbVie and CARE Therapeutics, and we'll move to the next slide. So I also want to acknowledge the Kulin Nation clans, who are custodians of these lands, both land and sea, and I want to pay respect to their elders, past, present, and emerging. So this is the talk tonight from me. It's fairly informal, and certainly at the end we'll have time for a lot of questions. They can be clinical questions, as Karen said, I'd rather not answer them specifically about how your hematologist is managing you, but more in a general way. So ask any question you want. I'm going to talk about what MPNs are. I know you know, but just for the audience, I'm going to talk about Jackson stats. I'm going to talk about NGS, and it's important for me to acknowledge Ken, who has been a great advocate for getting funding for NGS. So I don't know if you know, but in the beginning of July this year, thanks to the previous federal government, we have MBS funding now for NGS and MPNs. So you can get your blood tested anywhere now and get an MBS rebate. And we can thank Ken and a lot of other people, the Leukaemia Foundation, for that. And then I'm going to talk a bit about how I manage MPNs, but it's just my personal view, and a little bit about clinical trials. So what are MPNs? They're essentially complicated and simple at the same time. They're really, on the simple side of things, just excess production of mature, normal-looking blood cells. So these could be platelets, in which case your diagnosis is usually ET, or essential thrombocythemia. They could be red cells, in which case you'll have a diagnosis of PD. They're the two most common MPNs we have, and they can progress over decades into myelofibrosis, a more severe disease where a lot more research is focused. And unfortunately, myelofibrosis can be terminal and can also lead to acute myeloid leukemia, secondary AML, which is also very difficult to treat. But MPNs are a bit more complicated than that, and that there's this group of overlap syndrome, the myelodysplasia syndromes, that can overlap either at the beginning or through the journey one of you may have through an MPN. And they're characterized by the opposite problem, which is basically impaired blood differentiation. So the cells, you often have low blood cell counts, not high blood cell counts, and the cells don't function properly. And together, the mutations that cause both of these things can be bad in combination. Just a few statistics. Median overall survival for ET is 20 years. So as clinicians, the first thing we're taught, do no harm. So in the case of EP, often treatments are simple, either nothing, aspirin, a little bit of cyanide reduction sometimes, but given that the overall survival is that long, we don't want to reduce it by introducing therapies that are unwarranted. PV is a little less, and myelofibrosis less again. And when, as a clinician, I'm always thinking about, okay, that's median survival, but patients ask, what does that actually mean for me personally? And you'll see, I'm a hematologist, but also first and foremost a geneticist. So the genetic mutations that you have on top of the driver mutations are probably the most important thing that determines your AML risk. But on average, it's low for ET and increasing once you get myelofibrosis. So what's JAK-STAT signaling? It's the fundamental mechanism that our blood cells sense the need to proliferate. So if we're in the Ukraine war and lose a limb and bleeding everywhere, then the body responds to that, makes high amount of erythropoietin, EPO. EPO feeds back to the bone marrow and stimulates the rapid production of blood. The same for white cells when you have infections. There's granulocyte colony stimulating factor. It engages with that bone marrow to release and produce all these white cells to fight infection. Same with platelets. So the way JAK-STAT signaling works is these cytokines, EPO, thrombopoietin, CCS, they all work in a similar way. They bind to the receptor, which is a dimer, and they cause a twist of the dimer, and that activates JAK. So JAK2 goes from an inactive version to a phosphorylated or active version. And that active JAK2 activates other genes like the STATs, which you'll hear more about from Charlene. And these go into the nucleus, turn on other genes. And it's these other genes that cause the increased proliferation of blood. And normally this is a physiological response, but when you have a mutation in the JAK2 gene, then the bone marrow thinks it's confused. It thinks it should be making blood when it shouldn't be, and so the production of blood is in excess of what the requirements are, and that's where all the problems start. So, talk about NGS sequencing a fair bit through this talk, and my first question to myself and to you guys is, what do we need and what do we use NGS for? So, first and foremost, the diagnosis. So sometimes you can just get a simple JAK2 test. If it's positive, then you have a JAK2 NPM of some sort, and you don't necessarily need NGS. But increasingly, as I said in one of my earlier slides, NGS is a spectrum of different diseases and overlaps. So we have this little book as pathologists we have next to our microscope called the WHO classification. There's a new version that's just come out that basically requires a molecular diagnosis for most NPMs now. So we need the test to actually accurately diagnose. More importantly, it's for prognosis. So you'll see in a lot of the new prognostic scoring systems, they'll use gene mutations on some of the genes I'm going to talk to you about. And then last but not least, it's important to know what's wrong genetically with you to choose the right medicine. So we're using it more and more in clinical trials. For example, the CARE trial that I'll touch on very briefly requires you to have a normal P53 mutation. I'll explain a normal P53 gene. And then last but not least, you'll hear from Charlene, we can also use genetics to discover new genes, new targetable genes that might be the future of therapies. Again, you probably know about the driver mutation, so probably that JAK2, this particular mutation. Some people have a mutation, the second commonest is in a gene called CaRE or calreticulin that activates the pathway indirectly, and rarely again in the thrombopoietin receptor itself called MYPL. And then these other less common NPMs have other characteristic mutations that can diagnose someone that's been misdiagnosed for 20 years with a rare type of an NPM. For example, chronic neutrophil leukemia is an NPM due to a mutation in the receptor for CCS. So this is just, we've been doing NGS for 8 or 9 years now, kind of led the way in Australia and have a few publications in the space. This is just our 2 years of experience here at the Alfred, 2020-2021, where we sequenced 353 patients with NPMs. So we did this out of the goodness of our pathology director's heart without charging anybody, and before it was related, but thank goodness we can get some money back to do it now. And you'll see here, these are all the types of mutations that are fairly common. The red ones are the drivers I just talked about. And these ones here are important for prognosis. So they're quite common. It's actually moderately rare in more advanced NPMs just to have a driver mutation. There's usually 2, 3, or 4 other mutations. In PV and NT, it's often not the case. You usually just have the one. So what are these mutations? I don't want to go through all of the genes. They're there on the left, but you can categorize them into those that drive proliferation. So they're usually mutations in the JAKs or the receptors themselves, and all these other ones that are usually involved in negative regulation of the pathway. So if you lose a negative regulator, if you take your foot off the brake, then the acceleration is faster, and so the disease is worse. All right, so I'm going to stop on NGS and come back to it in a minute. I'm going to just give a couple of slides on PD to give my perspective on how to treat it, and a couple on ET, and then I'll move into myelofibrosis. So the whole aim of treatment of polycythemia vera is to reduce the risk of a thrombotic event, a vascular accident like a stroke or a heart attack, or even a deep vein thrombosis, or some cases of weird deep vein thrombosis like in the brain or in the gut. It's the same kind of thrombosis we saw with COVID vaccines, actually. And you're at a very high risk of these when you first present, because the blood is so thick and sticky that it needs therapy. So in PV, the treatment is aspirin to stop the platelets being sticky and venesections. And the intersections of the bugbear of a lot of patients. I get a lot of whinging about them. My veins have had enough. Why do I have to go every month or every 2 months? Can I do something different, please, doctor? So that's the standard of care. On top of that, we add other things if we need to. Remember I said we don't do things if we don't need to. So if we think the patient has high risk, and that's defined by various algorithms that essentially age, high white cell count, mutations, and abnormal karyotype, and there's different risk scores about how to incorporate that. But if you have high risk, you usually need to bring your red cells down with some other therapy. And the two we have are hydroxyurea, Hydrea, which is a form of chemotherapy, or Pegasus, which is the drug that's a long-acting alpha interferon that got on PBS thanks to the people in front here. They're the options we have in Australia that everyday hematologist can prescribe to you, but there are alternatives in trials. Ruxolitinib, which is the JAK2 inhibitor that's marketed by Novartis here, works really well in PV. It's just that the government won't let us have it for PV in Australia. So your hematologist can't write a script if you have PV or ruxolitinib, even though there's lovely trial data that shows a good drug in that space. But there are hepcidin agonists that are on trial here at the Alfred as an alternative way to change your iron metabolism in a way that the red cells are starved of iron without having the need for the injections. And there's some other novel agents which I might mention. What about ET? Again, I'm even more conservative with how I manage ET. Aspirin is all a lot of patients need. I often get asked, what platelet count is too high? When do I actually need more than just aspirin? And this depends on the driver mutation these days. So if you have a CaRE mutation, you have a much lower risk of a thrombotic event than if you have a JAK2 mutation. So people with CaRE mutations that platelet count of 1500, unless they've had a previous vascular event, I often just watch them. Sometimes give them aspirin. But don't cytoreduce them with Pegasus, which is a very effective drug here in younger people, and hydroxyurea. Again, we also have other drugs, anagrelide, which I'm not a personal fan of, but is an alternative if you're intolerant of some of the other drugs. Now, what about myelofibrosis? So myelofibrosis, as I said, is a more serious disease, and genetics are extremely important in myelofibrosis. So we now have the MIP70 plus scoring system, which you can just Google, and it's immediately there for any person. And there's a number of clinical parameters you can load into it, and a number of genetic parameters. So the clinical ones are simple things like, are you anemic? Are you severely anemic? Is your white cell count high? Do you have symptoms of myelofibrosis? So weight loss, sweating, things like that. That gives you a score. And then the level of fibrosis in the marrow, whether or not you have this CaRE mutation. So if you have CaRE, it's not as bad as the others. So you get a little tick for that. And then you get a big negative score if you have a 1 or 2 high-risk mutations. And there's 5 of them at the bottom of the slide there that every NGS panel in Australia will have. So you can go anywhere in Australia and you'll get AXL 1, EZH2, the IDH1 and 2, there's a typo. Sorry about that. It's IDH1 or IDH2, 2 similar genes, and SRSF2. So then you'll get a score and a prediction of your 5-year survival or your 10-year survival. And you can act on that information. Go back to your hematologist and say, this little thing tells me I've got a less than 30% chance of being alive in 5 years. What are you going to do for me? And see what they say. So this is the actual questionnaire, which I've just gone through anyway. So one thing we can do in Australia is ruxolitinib. Ruxolitinib is a good drug. Jacavi, some of you are on it. This is, I've been involved in clinical trials in Jacavi before I came here. I was involved in the first trial, the Comfort 1 trial in Queensland. And this is what's called a waterfall plot. And it looks at spleen volume or shrinking of your spleen. And compared to placebo, ruxolitinib is a really good drug in shrinking the spleen. And you also feel better. On a symptom score here, the placebo patients in grey started to get worse and worse if they got a sugar pill, whereas they got better on ruxolitinib. So these are the symptoms that many of you know about: sweating, fevers, bone pain, weight loss. In fact, some people put on so much weight on ruxolitinib that they want to go off it because they don't enjoy being fat. And I have to give them dietary advice and sometimes send them to a dietitian. One thing that does happen on ruxolitinib is you will drop your platelet count and red cell count quickly within a month. And it's not uncommon for a patient to come back to me and say, I'm more anemic than I ever was, doctor. This drug is not working. Can I go off it, please? And I say, no, just be patient. Your spleen will shrink, and then the hemoglobin will come up and you'll start to feel better. And actually, when people are still anemic on ruxolitinib, we'll talk about what we can do about it, but they usually feel better. They do feel better despite being more anemic, and often say, I don't need a transfusion. So anemia is a problem with ruxolitinib, however, and it's a problem with myelofibrosis anyway. I'm not going to talk too much because I don't have time about the other issues in myelofibrosis of low platelet count, refractoriness, progression, what we do about it. I don't have much time to talk about these things. I can talk about the bottom one in a word. Can you cure me, doctor? I often get this question. You're telling me about all these drugs and things, but can you actually cure me? And the answer is not without a bone marrow transplant. So we have a transplanter in the audience. Thanks for coming, David. I mean, allo bone marrow transplantation from a sibling or an unrelated donor, or a haploid from a child or a parent. These are all opportunities that can be taken. The decision to have a bone marrow transplant is a very complicated decision, and there's risks and there's benefits, and it's very difficult to know when you should have a bone marrow transplant, because there's quite a lot of mortality and complications associated with it. So in early phase disease like ET and PV, you don't need a bone marrow transplant. In myelofibrosis, you may or may not need a bone marrow transplant. If you wait too long in myelofibrosis, that you're not fit anymore, or you've got to an age where complications increase, then the risks then also outweigh the benefits. So it's a skill, and I would say the Alfred Hospital here has an extremely good and experienced allo bone marrow transplant unit, one of the best in the country, particularly in myelofibrosis. And we transplant quite a lot of patients here. Anemia, these are all the possible reasons for anemia that shouldn't be forgotten and the clinician should think about. If you're on hydroxyurea, that's often stopped. So someone has PV and they become anemic, and they've been on hydroxyurea, it's usually stopped, and sometimes it gets better. Some of these agents, I'm not a fan of, but there are other JAK inhibitors that may be licensed in Australia in the near future, such as momelotinib, which is different, that have different ways of acting that don't have the same anemia side effects. So watch out for momelotinib and the PBS in the future. And then we can add other drugs to Ruxo. One of them is this interesting drug that's been used in other blood cancers called luspatercept. And it can act to improve hemoglobinization and iron and signaling in red cells to make it better. So it's luspatercept is available on trial here at the Alfred in combination with Ruxo if anemia is your problem. I talked to you about improving survival, and then there's other disease modifying agents. So sure, there's an allo transplant, but what if I'm not eligible for transplant? What else can I do? We have interferon we talked about. There's some evidence that does improve your long-term survival outcome. We have BET inhibitors, we have telomerase inhibitors, we have BCL-XL inhibitors, and we'll hear about that in a minute, and other combination therapies. But just to remind you, ruxolitinib itself does increase your overall survival. So I think my time's up. I want to thank my team. One of them, Charlene, is about to give a talk. This is my team here in the ACBD. I want to also thank Lisa Butler, who some of you may know, standing there on my right, who's an emerging clinical lead in NPMs in Australia and won the Blood Albert Bakey Award for her research in NPMs just recently. So thanks so much for your time, and there'll be time for plenty of questions after the other speakers. I think if there's no time now.
Thanks so much, Andrew, for a clinical research perspective. Now we're going to move on to probably the most important part of the evening, I think, is the consumer perspective. So it's my great pleasure to introduce Mr. Ken Young. Ken has extensive experience in leading community and social services provision across a range of state government and not-for-profit settings, from youth homelessness, out-of-home care, leading care, through the creative areas, establishing digital arts and media opportunities for young people. His current role is partnership lead for the Southern Melbourne Primary Care Partnership. And Ken, relevant to tonight, was diagnosed with polycythemia vera in 1998. So he's certainly giving the survival predictions a good belting, which is great to see. The same year, he established the MPD Oz email support email list, which still operates with over 300 members. He's a founding board member of the Myeloproliferative Neoplasms Alliance Australia, a volunteer support group for patients and carers. We've heard he's been instrumental in a number of issues related to care and government influencing for MPN, and particularly in the area of genomic sequencing. The MPNAA has raised more than $100,000 for Australian-based MPN research. Ken has played an integral role in this. Thank you so much for your time, Ken. We're very much looking forward to your reflections on this.
Well, the secret ingredient, patients as partners. We're all being encouraged to work with patients, and it's been fantastic, actually, the work that the CaRE committee, and it's lovely to see Catherine Carmichael here this evening. She was the one who, along with Karen, dragged me into this setup, so thank you very much, Catherine. Patients as partners is a very difficult area. Some people say to me, but what does a patient bring to research? What does a patient bring to clinical care? And that's a question that it's about where your headspace starts at. It's where your expectations of what a partnership is. And partners are in many ways equal, but different. There's no way that I can match the skill and knowledge of Andrew, but I can bring my own lived experience, even simple things like when you have V sections or when you're constantly having bloods. There are some people, some phlebotomists who take the blood and it hurts every single time. Other people are very skilled, and I always, as a patient, say, "Oh, that was very good. I want to encourage them so that they keep doing it good." But patients see the whole role of our health as through a particular lens, and as Andrew alluded, can you cure me? Am I going to be what's the outcome? So like, what, 14 years? Well, I'm over the other side of that one, so feeling pretty good. But patients are very important in helping to frame the original questions, asking questions about what we are experiencing, so that you, as researchers and clinicians, have an opportunity to structure your research in a real world, the world of the people who are experiencing it. So much of hospital, it's all the rage. You know, there's the new clinical trial guidelines, there's the patients as partners standard 2 within your accreditation in a hospital. There's a whole range of areas where patients are important. People say to me, well, how do we engage? What's important? We had a very good discussion with Matthew when we first started this, Matthew, we call it, about how to frame the question. And I made some comment and he just said, oh, it was a light bulb moment for him. And it was about that process of engagement and talking. So I'll go through this. We've done the background. Well, I'd like to also acknowledge my close friend Natalie Cook, who is involved with the NPNAA. And one of the things we've been very active is as buddies also for researchers. One of the great things that Natalie was involved in was actually getting on the PBS Pegasus, just by having her tenacity and not letting go. And it's that sort of role that patients can also play as advocates. Sometimes we can, like Natalie was able to go and talk to her local member, Josh Frydenberg, and say, look, this is why it's important. This is how we can move this forward. We also have produced reports and submissions to the Senate. We've also been talking to the pharmaceutical companies. You mentioned momelotinib. I've been very right back in the day when it was Cytopia, and their involvement, and now it's gone to GSK. So there are ways in which patients can probably push around funding, around important other issues, and we also made a very strong submission to the NBS around the provision of NGS testing. So it's about a partnership may not necessarily be in the world of the clinical trials, but there's also the periphery, what happens around the treatment of patients and ensuring that the best available care is available. And I know Catriona is going to be talking about treatment pathways and some of the work that the Leukaemia Foundation are working in that area. And again, we as an organisation, NPNAA, are part of allies. We're volunteers within the Leukaemia Foundation, and we work very closely with them. Probably some of our successes has been, I think, including NPNs on the Australian Cancer Atlas, so that we're visible. We thought if we can be counted, we can be visible, we can advocate. And one of the really interesting pieces of data was the people who are living in regional and rural Australia, their access to blood cancer services is obviously much less, and possibly, you know, where does that come? If you look at the atlas, you can see that there's patches of NPNs across regional and rural Australia. I think probably the advent of telehealth through the pandemic has probably opened that up, and I know that Kate Burberry over at Peter Mac has been a fantastic NPN physician, but also advocating on the area of telehealth. So we also cooperate internationally. We've been involved with the NPN Research Foundation in Chicago, and we worked on the NPN interferon initiative with Stephen Langer up in Brisbane. So patients are more than just the people who you're treating or involved in research. We can be advocates. We have a very strong and important role in being advocates and being able to push in different directions where institutions and individual doctors might fear to tread. So that I've basically covered those points. It's around helping define the research questions and improving the relevance of research to patient need. And again, this for people who are involved with Monash and thinking about, oh, I've got to think about how do I involve researchers and consumers. There is a resource in the Central Clinical School that is there with enthusiastic and really fantastically young people who are really interested and really see the point of it and are really pushing for it. So if you're scratching your head, you've got resources, you've got a fantastic resource right at your fingertips. I think that's about it, because it's and the other thing is for people who are watching online, there is actually opportunities, real opportunities for real engagement. It's not just you might scratch your head as a consumer and say, well, what can I bring to it? You bring yourself, you bring your experience, you bring your views. And as a consumer, I found this group to be incredibly inclusive. And I think that if there are people out in the world who are NPN patients, and you're around Melbourne, have a think about how you might be able to be involved. I know there's been a number of NPN volunteers have come forward, and I think they're involved in some of the other projects. And that's where we are. NPN Alliance Australia.org.au. We have a lot of treatment guides. We indebted to the clinicians who have Andrew Perkins and Cecily Forsyth and others who look through our treatment notes to make sure they're accurate, up to date, and relevant. So that's an excellent resource, and we're slowly but surely now making our resources available in languages other than English. We have a very generous Arabic medical translator who's given us that work, and we've also just recently translated to Mandarin and Vietnamese. So there's a lot of resources there, and if you're new to the NPNs and wanting to find some support, I'd direct you there. Thank you.
Thanks so much, Ken. I think you've really highlighted at how many different levels consumers can play a major role in the shaping of the research and advice for researchers, but also in the setting of government advocacy and lobbying, as you say, in areas that we sometimes are a bit nervous to tread. So it really does show the full spectrum of consumer engagement and how important it is. Just like to echo one point that Ken made, there are lots of opportunities for consumers now. Obviously, this is an incredibly important one from Monash's perspective. But I was mentioning to Ken that government's now mandated that clinical trials need considerable consumer input, and this is not only in NPNs but across the spectrum of all clinical trials. The Alfred being the premier clinical trial provider in Australia has a very strong outreach program into regional rural areas to try and deliver a broad range of clinical trials for patients who live remotely. And again, if you have any interest in that or other aspects of consumer engagement, there is a place for you. It seems like we just need as many consumers as we can get our hands on. And it's new to the consumer community, I think, to think about how they might be engaged in these ways. But I certainly would encourage others to follow Ken's example and lead in this area and volunteer their services because we desperately need them. Right, back to the research side of things. And again, I would say it's my great pleasure to welcome Ms. Charlene Lam, who's a talented PhD student within the Australian Centre for Blood Diseases. Her research focuses on in vitro JAK-positive MPN models and blends these with state-of-the-art genomics technologies to really drill down and decipher the role of the JAK-STAT signalling pathway that Andrew referred to earlier, and what the downstream changes of activation of that pathway mean in terms of the proliferation of blood cells. And by taking data from all these variety of sources and integrating them, she really has the ultimate aim of trying to identify novel components within these pathways that are malfunctioning and offer themselves up as potential therapeutic targets. We have some targets, as Andrew's alluded to. We are constantly in the quest for other targets that will expand our therapeutic horizons in these disorders. As I said, talented and a woman, and that's been very much the focus lately of the National Health and Medical Research Council, which announced yesterday that they plan to now offer equal numbers of grants to men and women across all their research funding platforms, which I think is a seminal and hallmark day that's been long overdue in Australian science. So I think with that level of support into the future, looking more assured that talented investigators like Charlene, Karen, Catherine are all going to continue their journey to enrich the research environment. So I'd invite you to come to the stage and tell us about your assigned research.
Thanks very much, Steve. So it's a great pleasure for me to be here today because, I really wanted to share my research with the world and not just be, in the lab. And so first of all, I'd like to thank the organizers, especially Karen and Catherine, because I do think that it's incredibly important that we do, get together sometime and also share and exchange knowledge that we have. Okay, so as I've just mentioned, I'm a PhD student at the ACBD, and so for my PhD project, I've got a few different projects up there, and but basically, I guess for the main goal is to identify some novel target genes, novel target genes that I know targetable for MPNs. So to do that, I use different sort of tools and technologies to help me. So I use next generation sequencing and also use a mouse model. So it's a very useful thing to do. So what you can do is that you can manipulate the DNA and also probably introduce a JAK2 mutation into the mouse, and also do all sort of phenotypic assays to look at the disease progression and also drug these mice. And what you can also do is that you can do, overexpress some genes, knock some genes down, and see what it does to the cellular processes. And apart from these, I also work in the lab, and I do a lot of tissue culture work. So looking in here, so I use a lot of MPN cell lines. So the MPN cell lines do have the JAK2 mutations in them. So I work in a sterile environment. And I also use a lot of, work with a lot of JAK2 inhibitors and also other small molecule inhibitors such as BCL2 inhibitors and also B-cell inhibitors that I'm going to be talking about in a bit. So basically, I use all sort of different technologies to help me really understand how things work at a molecular level. So I know Andrew introduced this JAK2 signaling pathway, but I'll try to do a better job at explaining this in much detail. Yeah. So basically, you've got this JAK2 V617F mutation, but what does it actually do in a cell? So you've got this. Where's the pointer here? So just imagine this is the cell membrane, and this is the nucleus, and this is DNA. And you've got this receptors and cell surface. So what happens in in a normal person, which doesn't have the JAK2 mutation, is that you've got some like blood cytokines that binds to the receptor, and then it basically activates JAK2 kinase. So what a kinase protein does is that it basically put a phosphate group into some signaling molecules such as STAT3 and STAT5 transcription factors to basically activate them, and so basically these STAT3 and STAT5 transcription factors, they dimerize it, and what they do is that they translocate into the nucleus and basically look for the DNA. And they just don't look for any DNA, they look for like an open region of the DNA which has this specific sequence. So it's called the gap element, which they really love to bind to. So these STAT transcription factors basically bind to the DNA, and what it does is that it triggers the transcription of target genes. So we do know some of the target genes of the JAK2 downstream signaling pathway. So we know like TIM1, and also we know STISH, and also BCL-XL, which I'm going to be talking about in a little bit. So basically what these genes do is that it activates, so it basically let the cell know to increase cell survival, increase cell proliferation, and also differentiation from the progenitor cells to mature blood cells. So this is basically the overview of the JAK2 signaling pathway. So what happened to the JAK2 V617F mutation? So what it does is that it's a gain of function mutation. So it basically triggers the constitutive activation of the entire signaling pathway. So it keeps firing and firing without even the binding of the hematocyte, like the blood cytokines to the receptors. So that's what it does. But then I guess luckily we do have like a few JAK2 inhibitors that is available, to be used in the clinic and also for me to use in the lab. And they're the ruxolitinib, momelotinib, fedratinib, and pacritinib. And as I've said just now, I've used a few MPN cell line models. So we've got HEL cells and SEP2 cells. So they've got these JAK2 mutations, but then they've got like a different copy number of the JAK2 allele burden in these cells. So I guess for my project is to really understand how different these JAK2 inhibitors are, because we know that they've got like slightly different structures. So even though they target JAK2 kinases, they don't just target JAK2. They've got like different structures. They also target different JAK members like JAK1, TYK2, like JAK3. So basically what they do is that they target other kinases which have other target genes. So that's why when you treat the patient, you might have good response, but then you might get a slightly different side effects, or it might be suitable for some patients and not for other patients. So yeah. So this is basically the timeline of the drug development of these JAK inhibitors. So in 2005, we identified this JAK2 mutation. So that basically leads to the development of the JAK2 inhibitors. So in 2011, we have this ruxolitinib, which is a FDA-approved first-in-class JAK2 inhibitor. So it's a really great drug, as Andrew said just now. It's gone through a few massive international clinical trials, like the COMFORT trials. It showed a really good response rate, and also it alleviates symptoms and also reduce spleen size. And it also does quite well in patient survival as well. But then you do run the risk of resistance and also intolerance over time. And in 2019, this fedratinib drug was approved, and apart from inhibiting JAK2, it also inhibits FLT3. And the trials also showed a very good clinical benefit in myelofibrosis patients. And early this year, I believe it's in March, pacritinib was approved by the FDA. So it basically inhibits FLT3 kinase. And what's slightly different about pacritinib is that it's got minimal activity for JAK1 and JAK3 and also TYK2. So what that means is that this drug is a little bit less immunosuppressive compared to others, and it could be a good option for patients that have a high risk for infection and also have a low platelet counts. And for momelotinib, it's not approved yet, I believe, but I'm pretty sure it's going to get approved pretty soon, probably in sometime next year. So it also inhibits like JAK1 and TYK2, and it's got very promising results from several trials like Simplify study. And basically, it's a very good option for anemic patients for who has MF. So it has like a reduced requirement for blood transfusion. So that's that. So before talking about my study, so I really wanted to understand, like use different techniques to really understand, like compare and contrast, like the similarities, the difference in how they work. So I wanted to look at like different aspects of how they work, like how they inhibit the cell viability in MPN cell lines. I want to know if like how potent it is in inhibiting some like transcription factors like STAT3 and STAT5 that I just told you about, because they're very essential in triggering a transcription of the gene. And also wanted to know like what different target genes they target. So that basically gives us like a implication of like the side effects and that sort of stuff would be very helpful. So yeah, so the first thing that I did is that I used, so this is called like a dose response assay that I did. So basically I treated the health cell lines, so they've got this JAK2 mutation for 24, 48, and 72 hours with an increasing dose. So as you can see for the y-axis is like it represents the absorbance, so it correlates with cell survival. So the higher the dots, the higher the cell survival. So as you can see here, the higher the concentration, the drug does inhibit cell survival. And you can see like a similar trend across these drugs. So then you do see like they do differ in potency. And we do believe that this inhibitory effect is mediated by the downregulation of the STAT transcription factors. So what I'm showing you here on the right is that when untreated, so when you don't treat the cells with JAK2 inhibitors, and you can see like a high level of STAT5 transcription factors activity. And if you treat them with these drugs for 1.8 hours, you can see that the STAT5 level is inhibited very well. And for some other drugs, the STAT5 level tend to like come back over time. We're not sure why that is, but that's the way it is, I guess. And so moving forward, now we know that these JAK2 inhibitors, they do inhibit STAT5 transcription factors. So it's not surprising that they would inhibit a few target genes as well. So here I did a RNA-seq to basically look at a change in gene expression after like the treatment of these drugs in the health cell line. So this is just a heat map, and what it's showing is that the red color just reflects the higher mRNA expression, and the blue color reflects a lower mRNA expression. And the rows represent the target genes, which I'm not sure if you can see here, but just the target genes of the JAK2 inhibitors. And the columns it shows the treatment duration of the drug. So as you can see very clearly, as you treat the cells with ruxolitinib, you see like a downregulation of a lot of target genes. You see like IT1 and also PIM2, which is a known target genes of the JAK signaling pathway and could be a good target for MPNs. Just needs more validation. So we also see a similar trend for other JAK2 inhibitors in fedratinib, momelotinib, and pacritinib. But then like even though the trends are pretty similar, if you look closely into the gene list on the right here, we do see like a few overlap target genes, but then we also see quite a few like novel ones, some unique genes that only exist in 1 or 2 of the JAK inhibitors. So that is very interesting. And yeah, I guess the point is that I identified a lot of interesting target genes. I can't go into like every single one of them today, but then I do want to highlight a very cool and exciting genes that we found, which is called BCL-XL, which some of you might have heard. So basically, BCL-XL gene, it encodes the BCL-XL protein. So basically, the BCL-XL protein belongs to this family, BCL2 family proteins that control cell death. So a lot of studies show that patients who has this JAK2 P617F mutation, they do have a overexpression of the BCL-XL, which makes it a very promising target for MPNs. And luckily, we do have the small molecule inhibitors that target these, pro-survival proteins. And, we've got this, venetoclax, which target BCL2. We've also got, venetoclax and also this specific inhibitor that only inhibits BCL-XL. So this is just some dose response assay data showing that if you treat the cells with venetoclax and also this BCL-XL specific inhibitor, you see like a very potent inhibition in cell viability, and they also cause cell death as well. And compared to venetoclax, which MPN cells is not dependent on BCL2, so venetoclax don't really inhibit the cell growth of the MPN cells. So what it shows is that these 2 drugs are very are pretty specific and should be fairly safe for MPN cells. And so I want to talk a bit about venetoclax. Before you don't have time for this slide. Okay, let's skip this. Okay, so I want to talk a bit about this clinical trials that I think it's running in the Alfred as well. So it's basically looking at the combination therapy of venetoclax and also ruxolitinib in JAK inhibitor naive patient with MF. So so far it's been showing some very promising results. And I might show you a figure here. So this is just a waterfall plot, just showing that when a patient get treated with these combination therapy, you do see like a vast reduction for the driver G mutations. So not just the JAK2 mutation, but also the CaRE and also MYP mutation. So you can see that this effect is as early as week 12. So very promising. So this brings me to the end. I do think it's very optimistic in terms of therapeutics. So I think it's very hopeful. Everyone's like doing their job in the lab to look at like different aspects of the disease and also drugs as well. So like from 2005, and we identified a lot of gain of function driver mutation and even the rare mutation, passenger mutations. And this basically helps the WHO to classify the MPNs a little bit better. And a lot of like clinical trials have been going on and leads to the FDA approval of a lot of amazing drugs, which works pretty well. And apart from these, we've got some, very promising combination therapy. We've got some novel, monotherapeutic agents as well. So yeah, I think the future is bright. And yep, that brings me to the end of my presentation. Thanks very much for listening.
Thanks, Charlene. Definitely a much clearer explanation than Andrew, I thought. So, I think that's a great example of what translational research is all about, where you can see somebody is in a tissue culture hood with a cell line doing work, then through mice, genomics, and ultimately you see translation into a new clinical trial based on observations that have been made at that basic level. And one of the great advances, I think, and advantages of being at the Alfred, because you've got basic science labs literally within a stone's throw of 600 patients, and that interface between the clinical and the basic is critical to advancing research rapidly into outcomes, which is what we're all about. So the last speaker tonight is Catriona Rafael. Catriona is the Manager of Policy and Advocacy for the Leukaemia Foundation, a very important organisation with a very rich history in this country. She's assisted with the National Strategic Action Plan for Blood Cancer as Secretary for the Blood Cancer Task Force, helps manage implementation of its recommendations, including the development of 6 optimal care pathways for blood cancers. And I think anyone who's worked in the haematology, and particularly in the blood cancer space, can't really understate the importance of the Leukaemia Foundation for many years in this area. So, Catriona, thanks so much for joining us. We look forward to sharing your
Catriona, please pretend my hair still looks like that and hasn't been destroyed by the community. As hopefully most of you know, in 2020, the Blood Cancer Task Force, for which the Leukaemia Foundation is the secretariat and helps do a lot of the implementation work, released a National Strategic Action Plan for blood cancer. And its initial projects that we're really aiming to get up are focused on setting national standards. And I'd really like to thank the more than 4,500 people who signed up to our Set the Standard campaign to help promote national standard setting to the federal government. And we're excited to see some of that work come to fruition in the upcoming Australian Cancer Plan. The development of the optimal care pathways for major blood cancer subtypes is the first recommendation to be delivered from the NAP. And through the development and implementation of these blood cancer OCPs, the task force's aim is to set those national standards for delivery of best practice treatment and care, which will lead to better outcomes for all people living with blood cancer. What's an OCP? Optimal care pathways describe a model of cancer care that puts the patient at the centre of their care decisions. They're not a clinical guideline, although they do heavily reference them if they are available, and unfortunately clinical guidelines are not readily available for most blood cancers. But OCPs are a holistic framework for the delivery of consistent, high quality and evidence-based care. The OCPs are underpinned by 7 basic, what we think basic principles, encompassing establishing a patient-centered approach to care from the very start, ensuring systems are in place to deliver multidisciplinary coordinated healthcare, identifying and addressing the supportive care needs of patients throughout the entirety of their cancer journey from diagnosis through to aftercare, meeting their communication needs and supporting them to have those discussions that they need to have with their treating teams, and incorporating discussion and awareness of relevant clinical trials, which is really important because only a third of people with blood cancer ever have a discussion about a clinical trial with their clinician, which is something that we are trying to change. The disease-specific components of each OCP go through a series of 7 steps covering the continuum of a person's cancer experience. This includes early detection, referral, diagnosis, staging and treatment planning, optimal treatments for their particular blood cancer and the specifics of their cancer, recovery, relapsed or refractory disease, and end-of-life care or palliative care. Each stage considers the supportive care needs of patients and the training and experience required of the treating team. Each OCP is made up of 3 documents, and here's the one we did for CLL. The full OCP is a technical document, and it's really intended for physicians, outlining in detail the components, pathways, and timelines that define optimal care for someone diagnosed with this particular type of blood cancer. OCPs can provide value to the health system as well to identify gaps in current cancer services across the nation,
and bring about quality improvement initiatives and hopefully improve how services are coordinated and planned across the country. The second document is the quick reference guide, a 4-page summary version of each OCP, primarily aimed at health professionals and health services. These guides include really, quick checklists related to recommendations in the OCPs, including referrals and support services. And these are also intended to really support primary care in helping identify blood cancers. Finally, and probably most importantly, is the guides to best cancer care, which are summaries aimed at consumers, carers, and their families. These guides can help people know what to do, who to go to, what questions to ask, and are intended to empower patients through their experience of their cancer. And these guides have been translated into the 8 most common languages in Australia. And Ken, I might steal your Arabic person because we have a lot of trouble getting our Arabic translation reviewed, but hopefully all of these guides are able to support a greater number of people than might have been previously. Collaboration has been a necessary and critical part of the development of the OCPs, with a working group for each OCP led by an expert in the disease and supported by a consultant who helped with the initial desktop research. These working groups consisted of disease specialists, patient representatives, GPs, and other specialists from areas such as cancer nursing, radio-oncology, pathology, fertility preservation, psychology, and palliative care. The OCPs were further refined through consultation with expert critical review groups and then open for public consultation and feedback. Each OCP also had to undergo a lengthy nationally approval process with each state and territory health government as well as the federal health department. And hopefully this will be a little bit more streamlined now. So we have produced 6 blood cancer OCPs so far, including acute leukemias in children, adolescents, and young adults, which also married with an existing OCP for childhood cancers. CLL, CML, low-grade lymphomas, multiple myeloma, and MDS, joining 2 existing OCPs developed by the Cancer Council of Victoria, which was for AML, Hodgkin, and DLBCL. We are also in the process of developing additional 5 OCPs for Waldenstrom's, CTCL, ALL, AL amyloidosis, and of course MPN, which is where you come in. Our expert working group for the MPN OCP has all these wonderful people lending their time, their brains, their experience to help produce a comprehensive, representative, and evidence-based OCP, which will hopefully look better than that. And we will need your help. We will need considerable stakeholder comments through several rounds of consultation, including feedback on the OCP itself and the quick reference guides starting from the end of this month. So look to your emails because we'll be hopefully getting Ken to help us get some people. Thank you, Ken. And we'll also need feedback to help develop the consumer guides and promote it through your networks and to your patients, carers, and everyone you know once it is finalised. And you can access these through, well, actually QR code. I'm not sure if it works in the room, but hopefully for people online, you'll be able to just use your phone to access it. And they're also available on a specific website, which is like a progressive web app. It's quite fun, actually, all this technology. So the optimalcarepathways.com.au and also from the Cancer Council website. And finally, I just want to plug much of the National Action Plan, including the OCPs, was based on the 2018 State of the Nation survey, which was a massive survey of people living with blood cancer, their families, and carers. This data was instrumental in being able to promote our research and our suggestions to government and really gave our advocacy the data push that it needed. We need your help again. We're rerunning the survey and we need your experiences. Last time we had 3,200 responses and we're hoping to do better than that this year. The survey can be accessed from the Leukaemia Foundation website or there, and it's right on the front page of our website. And thank you so much for having us tonight, and thank you, Ken, for following up with the video. I think I tried this, what, 2 years ago? Yeah, thank you so much.
Thanks, Catriona. It's a fantastic initiative, very exciting both for clinicians and for patients in the community. So thanks very much. Just again, like to thank our 4 speakers. We've had a great spectrum of some clinical, some science, some consumer perspective, some ongoing advocacy. And again, if you'd all just join me again to thank the 4 speakers for their contribution this evening. Also to really thank Karen and Catherine as the instigators, but now the broader CaRE committee, some of the members are here, other members who aren't, for the work that they're doing. It's a model that was initially established in the haematology department, but I think it was so well respected and admired across the entire Central Clinical School that I think every other clinical department put their hand up, and like good ideas that we permeate widely, and now the whole university, I think, is looking at this model thinking, yeah, this is what we've got to get into. So I think they've set the benchmark, very high standard that others are now looking to emulate, and mimicry is the greatest form of flattery, and you can be well recognised by the number of people who want to do exactly what you've done. So thank you very much to founders and the ongoing members of the CaRE committee for all of your work. All right. We've now got an opportunity for some questions. So I'll try and pick out who I think is the most relevant speaker to address these two. And the first one, I think probably Andrew, you went on. So this is, there are no names, I'll just keep the questions broadly. Somebody writing saying that they have a myeloproliferative neoplasm, but they don't have a JAK2 mutation. What's the significance of that? Are there other genes that are unknown that are driving this? What's the relevance?
Yeah, it's a good question. So in order of frequency, JAK2 comes first, and then calreticulin or CaRE is the next most common mutation that works in the JAK-STAT pathway. And then we have rarer mutations that MIPL, which is the receptor for the thrombopoietin ligand, would be next. And then there's a whole suite of rare mutations that are worth looking for if your clinician thinks you have an MPN, but you're JAK2 negative.
Okay, thank you. The next question is about tracking of progression with MPN. And we touched a little bit on this in myelofibrosis, of looking for how the disease can change, developing some symptoms and so on. As a sort of generic comment, I suppose, about tracking the diseases.
Yeah, good question. I get asked this. I mean, this is a conversation with patients a lot. You know, they ask me that question, how do you know if I'm doing okay or going downhill? So clinical parameters, I mean, first and foremost, how the patient feels, like listen to your patient. And symptoms of, there's an MPN 10 scoring system that Ruben Messer, that some of you know, has developed. It's a simple 10-point scoring system for symptoms that patients should look out for and tell their doctor, I'm not feeling as well as I did a year ago. I'm now sweating every night, or I'm losing weight. And there's a system there that you can actually write a score, and I actually use it and put it in the patient's files. So if there's a clinical deterioration, and we have some other measures of progression, like if your blood counts change, there's a few immature cells in the blood, then it's time to have that investigated. That might mean a bone marrow biopsy that you don't want to have, or it might mean, and likely means these days, another NGS panel run to see if there's been a change and you've got something new that's responsible for the downhill change. So bone marrow biopsy, I mean, if you're the patient, remind your hematologist that you're not as good as you used to be, and that would be a flag to investigate it.
Right. The next one, I think I'll ask Ken and Catriona both to comment on, which addresses the area of education in general practitioners. Obviously, especially in Ireland, we hope we all know about MPNs, what to do. But obviously, in the world of general practice, these are not diseases that GPs see a lot of. Obviously, much less familiarity. So, interested in your perspective, Ken and Catriona, as to where we go from a general practice viewpoint to try and make sure that we've got a broad education.
I think it's actually, I'll tell a slight personal story. My son-in-law, who I bashed around all his relationship with my daughter, I did mention that I had MPNs and all the rest of it. When he did his orals, the descriptor was a person with ruddy complexion and gave the straight PV thing. So he got a good start for his orals. I think that patients have to become their own advocates. Sometimes that's at some risk of Dr. Googling absolutely everything, but patients do know our bodies best. And I defer also to Natalie, who you went through a stage where your body just wasn't right.
Yes, that's right. Yes, so I'd had sort of vague symptoms for a long time of sore hands and itchiness, and but they all seemed and slight headaches, sort of visual disturbance in my vision from time to time. And they all seemed to be sort of nondescript things. And for a long time, I didn't go to the doctor because I thought, oh, it's only a minor thing. Maybe I've got a bit of a migraine, busy, I had young children, etc., working, all of that. And then it was when I finally went to the doctor, it was because I was at work one day. I'm a dietitian. I was writing in a patient's file, and all of a sudden it was like I was looking through water. I thought, this is not right. Am I having a stroke? What's happening here? So I actually called my GP and told him, and went off and had blood tests, etc., and went to an optometrist and had a brain scan, and ended up being sent to a hematologist. And when I got that referral to see a hematologist and it had query, question mark, myeloproliferative neoplasms, I thought, what the heck is that? I've never heard of that in all the years I've worked in healthcare. So of course I go home, jump on the computer, start reading about it. And then by the time my husband came home from work that night, I was saying, oh, I might get myelofibrosis, etc., etc. So this was in 2008. And I couldn't find any information at that stage. There was really nothing happening in research in Australia in MPN. And so I ended up going over to the Mayo Clinic conference, which I found Ken's support group. That was the first thing I found. And then through that, I was opened up the whole community online of people with MPN. And then I heard about the Mayo Clinic biannual conferences and went over to the first one in 2000. It was 2009 was the first one I went to. No, 2008 it was. Yes. No, sorry, 2009. But anyway, it was absolutely, so as Ken said, it's a matter of looking for things. And I always say to patients, look at the source, make sure it's a reputable source of information. Who is it from? Because I get that a lot as a dietitian with people things on Google that are not evidence-based. So you're absolutely right, Ken. Sorry about that long answer.
Yeah, so disease awareness is something that the Leukaemia Foundation is advocating for at an entire healthcare level. You know, I don't think a lot of people necessarily connect, for instance, blood cancers with MPNs. Sorry, I can't say that. Awareness of the disease and disease groups are certainly things that we're very aware of in you know, a lack of awareness in primary care. And the OCPs that we've been producing are not targeted at addressing that, but it's certainly aimed at helping that. And we're working very closely with the RACGP to support them to give this information to their GPs and hopefully raise awareness of, you know, GPs who might see one case of AML in their entire career, you know, one case of MPN in their entire career, or even if they see it at all. Obviously, the problem with these kind of rare diseases is that you have these GPs who are, the first line of defense, I suppose, in detecting and managing these diseases, and they may not recognize it when they see it. So producing these OCPs and other aspects of setting national standards is also about ensuring they get to the GPs and they're supported with information and they know where to look for confirmation of a suspicion, for instance. So it is a problem. It's not an easy one to solve, but hopefully the OCPs and other materials that are being put together through the Australian Cancer Plan will help address that.
Okay, thank you. Andrew, maybe you, although Catriona, you can probably comment on this potentially as well. The possibility that ruxolitinib will be licensed as an option for PV in the future.
Well, that's a good question. Well, Nevada's attempted that with support from a lot of the hematologists you'd heard about, and including myself, and we fell short of convincing the regulatory authorities that it should be funded in Australia, but we can always try again.
Catriona, any luck there?
I actually don't know the submissions for PV, but it has been up recently, or potentially next month, for a different indication. And I think the more times the drug is recognised for other conditions, the greater the likelihood it might be recognised for rarer ones. And unfortunately, a lot of these decisions are less about the clinical efficacy and more about the cost.
It's cost. So we were basically told people with PV live too long.
Yeah.
We can't afford to give them this drug. That's the short answer.
Yeah, particularly for drugs that you take essentially for the rest of your life. It's not like a discrete treatment period, it's an ongoing treatment. And
there's no need to.
Where is it off patent?
Oh, soon.
You repeat the question, please, otherwise.
Yeah, good. David Curtis asked the question, a good one. When is ruxolitinib off patent, and therefore biosimilars could be produced at a lower cost and make it more available for a broader indication? The response trials, which are these big, large, well-designed trials, show that it's a good drug in PV. You don't need a resection again if you're on ruxolitinib.
Got a clue your audience, actually, some great questions here. So one question is, if I have a JAK mutation, do I automatically have MPN?
Oh, wow. David's here as well, which is good. No, not automatically. So, it comes back to a concept called a VAF, variant allele frequency, or VAF. So it's for all cancers, actually. It's not uncommon to have a mutation in a subpopulation of your cells that's somehow held in check by the body. A good example would be the difference between a mole and a melanoma. MPNs are like the moles, and they can start very low level JAK2, and some studies suggest that JAK2 mutation that eventually comes to be an MPN can actually start as a teenager or even younger, and you've had it for 20 years before you even know. But it's usually slowly accumulates, and David would tell you in some cases there's a disorder called clonal hematopoiesis where you have the mutation, but the cells are normally number, and some of them will progress to an MPN, and many of them will just sit there. So the short answer is you don't have an MPN until you have too many blood cells in your body, but there's a danger it will turn into an MPN in time.
Question talks, sort of emphasising the importance of mutations in the progression. Somebody's asking, how often should a patient be tested to determine if new mutations have arisen?
Well, luckily, we don't have a restriction on the item code for retesting. So in the case of myelofibrosis, you can, Kate Burberry would do it on a yearly basis, often, as she tells me. I think if there's a clinical change that you think a genetic test will lead to some action, then it's definitely worth doing. But so I think, you know, every 2 or 3 years, or if there's some reason to do it more frequently, like you're worried that AML's around the corner, there's something that worries the patient or yourself. But, you know, in the past, there was a limit of cost. But the test is cheaper and cheaper to the taxpayer, and therefore it's, you know, more and more relevant to do them more frequently.
There's a lot of unsubstantiated chat about hydroxyurea being a driver of acute myeloid leukemia, and people were worried about being on this, which is a chemotherapy agent for long periods. Just want to comment on the evidence for or now against that, Andrew?
I could ask one of the patients that might have been offered. I might ask him to answer it first, what he thinks, because this is a common question.
My experience of hydroxyurea was terrible. I had almost within 6 weeks starting it, I had ulcers from my lips through my tongue into my upper respiratory tract and terrible ulceration in the legs. I just didn't tolerate it at all. So within about 6 weeks, I was off it and then on to Rafael.
Yeah, my view on this, in terms of leukemia risk, is that, well, we changed the names of these disorders from myeloproliferative disorder to myeloproliferative neoplasms for a reason, and that is they are in themselves a cancerous or a precancerous, depending on what you think, disorder. So without any hydroxyurea being there at all, there is an inevitable risk of getting leukemia. So I think most of the data suggests that hydroxyurea doesn't increase that risk, but you can easily see how you can put 2 and 2 together and blame the drug for your leukemia down the track. There are other drugs that have been used in the past, like radioactive phosphorus, that are leukemogenic for sure, and busulfan is another one that's used that I am a bit more suspicious about leukemia risk. But you know full well that in sickle cell disease we use hydroxyurea from on little kids before they're 10 years of age, and they never get a leukemia signal. So I think it's a safe drug.
All right. Some from the floor, might be the last one. Oh,
I was going to make a comment that supported what Andrew just said. I did have questions too, but as far as the hydroxyurea was concerned, I have myelofibrosis now, but I've been through a pathway that was ET and then turned into myelofibrosis. I had the hydroxyurea for 10 years and had 0 problems with it, and was gleefully looking forward to it lasting forever. And things changed, but I couldn't put my finger on anything to do with hydroxyurea.
But some people have ulcers. It's a known side effect, and they just can't tolerate it. So, yeah, I think the jury's still out on some other potential side effects. I'm not saying it doesn't have side effects that are a bit subtle and hard to pin down. It could do, but as far as leukemia and your ultimate demise, I don't think you can blame hydroxyurea that your hematologist is giving you.
All right, thank you very much. That concludes our question time.
Thanks, Steve. Yeah, wow, great questions. Thank you, everyone in the audience and online. So, in the name of the CaRE committee, this would be, of course, not possible without our sponsors and without support. So I would like to mention here the MPNs can. Thanks again for the great input you're giving us to the CaRE committee and to share your experience with that with us. It's amazing. Thank you. Thank you to the Alfred Foundation, who partly funds our program. The Leukaemia Foundation for their support tonight. Thank you. Advocacy and CaRE Therapeutics. Thank you. Of course, Monash the CCS committee, all the members who helped to organize this event and to keep this program alive. We're doing that next to our job and on top to our job because we believe on it, that we need actually your input as consumer, as advocate in our research to improve our research. One last question, could you please fill in the survey, which will pop up when this webinar ends? We would like to improve for further events we are planning to do. And people on site, I'm really pleased, thanks to the sponsors, to say that we have little refreshments in the foyer for you. You're welcome as well to fill out the survey. They're popped up everywhere, or you can just talk to us. So have a lovely evening, stay safe, and all the best. Thank you.